Hello, my name is Karen Johnson. I'm the Senior Vice President and Chief Clinical Officer for the Universal Health Services Behavioral Health Division, which owns and operates more than 330 facilities in the United States and the United Kingdom. We provide services in all settings across the lifespan, from inpatient to outpatient, school-based, residential treatment, substance use, and specialty care throughout all of our operations. I also have the distinct privilege of sitting on the executive committee of the Action Alliance for Suicide Prevention, a role that I have been honored to serve for nearly 10 years. As I reflect upon the last 10 years of our support, as well as the overall growth of zero suicide adoption, I'm struck by a number of issues that have become clearer and clearer over time. This also includes that while the name zero suicide at times can seem nothing more than aspirational, without having audacious goals in front of us, we will miss what is most important. The hard work, the hope, and the passion to continue moving towards a time where no one feels the despair or the loneliness or the desire for relief, but feels hope, is what drives me and drives us all around the world to continue to push forward. With sustained effort, we can do more. We have to. It is imperative that we continue to make every effort to impact lives so that each day healing and recovery can occur. COVID taught us a great deal, not all of it negative. What it did do, unequivocally, is change the conversation about mental health. It allowed many individuals who were more previously silent about their own mental health challenges to speak up and share with the world. It was a breath of fresh air to someone who has spent their whole career representing individuals who have not been given a voice or who have been silenced. It also made the conversation of providing total health care a real possibility, meaning that you can't have good physical health without good mental health, and vice versa. If individuals and agencies and communities are willing to share their experiences, it provides hope and healing as true opportunities. The costs and consequences of providing one kind of healthcare versus the other is enormous. Just reflecting back on the years in lockdown is a reminder of that. While we were searching far and wide for personal protective equipment, we were also searching for solutions to support mental well-being. They are interconnected, or two sides of the same coin, and cannot be separated. At UHS, we began the journey to understand the elements of zero suicide all those years ago. The work started with two related tasks: improving care through zero suicide from the UHS perspective, and transforming the industry based upon our learnings. The concept of suicide care was just what we did. We didn't label it as such. We didn't talk about it explicitly, but we certainly took care of thousands of individuals suffering with suicidal thoughts and plans. The goal was always to keep each individual safe while in care with us, and quite frankly, hope and pray that the care transition to outpatient services or another level of care was available and capable to continue what we started. I assumed before we began that we were experts at providing care to individuals who were suicidal. I was confident that there wasn't much more that we could learn, and boy, was I wrong. Our physical spaces were safe enough, without a doubt, but without being prepared to address leadership and a leadership commitment, evidence-based care curriculum, lethal means restriction, and patient assessment, While looking at ways to improve, we were only skimming the surface. What can be done in just a few days? A whole lot. Setting the groundwork for that care transition was our responsibility, but there is more to be done. Breaking through the myths of suicide-safer care has been a critical and important process as one of the largest global healthcare systems as well. How do we talk about zero suicide and make it real while acknowledging that it is hard? We just do it, to borrow a slogan from another industry. Transforming our capacity to thoroughly risk assess, provide competent care, and prepare for discharge are the true goals of our work. Lives depend on it. And we have been entrusted with taking care of not just who is in front of us, but their families and their communities, as well as the communities we serve writ large. When I went to school for social work a very long time ago, I was not taught about suicide care. I didn't connect those two words together even in the same sentence. I learned, sort of, what to do if a patient of mine was in crisis. Do a wellness check by calling the police. I'm so very pleased that there are other options available now, that 988 exists, that zero suicide exists, and individuals like you are motivated to do the hard work in your communities around the globe to improve our capacity and capability to provide hope to those who need it. It is worth the effort. It has to be. I am often asked about my why. My personal why comes from a deep desire to ensure that each life is valued and valuable. What can be done in community is much stronger than what can be done in isolation. The power of partnership is key. The Action Alliance has convened extraordinary public and private sector partners who share the desire to instill hope and provide healing and recovery for those in need. We can't do it alone, but we can do it, and we must. I'm struck by a comment that many of you have heard before. It has stuck with me for years. If it is not us, then who? If it is not our responsibility to carry these efforts forward to impact lives, then who? We must accept this responsibility and act on it responsibly. If it is not now, when do we think it is time? I hope that each of you will join us on this journey to sustain our efforts. It is never too late. Thank you.
Hello, I'm Dr. Ian Dawe. I'm a staff psychiatrist and former medical director of the mental health program at Trillium Health Partners in Mississauga, Ontario, Canada. I'm an associate professor of psychiatry at the University of Toronto and an investigator at the Institute for Better Health here in Mississauga, Ontario as well. I wanted to talk a little bit about the power of storytelling, specifically with regards to leadership in suicide and suicidal behaviors. And along those lines, I thought I would make a first disclosure. I have done some public service consulting work with Health Innovations Group and Deloitte Canada. I'm a former employee of Ontario Shores Centre for Mental Health Sciences, one of our public specialty mental health organizations, a former employee of the Central East WIN, regional governance structure in Ontario. And my appointment at the University of Toronto is status only, not salaried. Importantly, I don't accept direct industry funding, honoraria, speaking fees, those types of things. So I welcome your feedback on today's topic, but any thoughts and criticisms are directed to me solely. I appreciate that. The concept of storytelling in this topic, how did suicide prevention become my leadership focus, my clinical leadership focus, my administrative leadership focus, and why I think it should be a healthcare priority for you and for systems broadly across the world. As I started out my leadership journey many, many years ago, there were really 4 key priorities that I wanted to implement, and I think have influenced all the work that I've done. The first was all about reducing variation. The concept that somebody could experience a different journey in the healthcare system on a Tuesday morning versus a Friday evening would keep me up at night as an administrator. I really wanted to work on reducing variation. I also wanted to work on making it easy to do the right thing for our clinicians, for our partners, so that they could learn what was working across the world and implement that in an easy fashion. Technology has been a godsend with regards to this structure. Using data to shine light, but not to shine heat, not to point out individual failures, not to do quality assurance, but to do quality improvement. And measuring outcomes. Measuring outcomes, of course, really using that data to drive continual moving forward. And when we were looking at data, when I was getting involved in this early on, it was not encouraging. The suicide rates in Canada for these years in 2011 were virtually unchanged across the province, with the notable exception, of course, of our First Nations population on the far right of this slide. That a national tragedy, that a topic in and of itself, for sure. The suicide rates in Ontario, our local suicide rates, also disturbingly flat. Across many, many years, these rates were not changing. And that was very difficult for me to understand because of the lack of variation in the rates. So I wanted to work at a systems level. And I have to give credit to one of my administrative colleagues, Dr. Karim Mandami, who is currently the CEO and the president at Ontario Shores Centre for Mental Health Sciences, where I was formerly the physician-in-chief. He gave me the opportunity to work at a provincial level, chairing the Ontario Hospital Association's Task Force for Suicide Prevention. And this was really one of my first opportunities across a broad regional, provincial level to get involved in suicide prevention broadly and to advocate generally. It allowed me, I think, my first exposure to the concept of zero suicide and the Zero Suicide Institute, because across this work, we really were able to study what was happening in the world, what was working, who was doing what at scale. And those concepts began to influence what we were doing here in Ontario. Obviously, the summary of the recommendations on the right side of this slide gives voice to some of those things that we learned. The concept of implementation of the zero suicide model. The notion that our hospitals needed to focus on improving their physical environment and their infrastructure. And in Ontario, we needed to work on the data to make sure it was contemporary and up to date, so that it was describing what was happening in real time, not what was happening 5 years ago or 10 years ago. As we started to move out from that provincial task force report, I began to become influenced by some key people. And I wanted to give thanks to them briefly here. Mike Hogan, an incredibly influential person in my journey through the zero suicide movement, a quote like this: "Suicide represents a worst case failure in mental health care. We must work to make it a never event in our programs and systems of care." I remember him saying that in a conference that I attended, and it really rocked me in a positive way to hear somebody throw down the gauntlet like that, to target suicide and its prevention as a must do. Similarly, Richard McKeon, quote, "Over the decades, individual mental health clinicians had made heroic efforts to save lives, but systems of care had done very little," end quote. That was a key moment to hear, to understand, and to contemplate the implications of. Because for me, zero suicide has never been about individual change or individual successes or individual failures. It's not zero tolerance. It's improvement across a broad scale. And that notion of systems of care became, for me, the main focus and driver of the work that I wanted to do. Thomas Prieslack, quote, "It's critically important to design for zero, even when it might not be theoretically possible to achieve. It's about purposely aiming for higher levels of performance." This was also a key informant in the journey of how I wanted to go about trying to implement a zero suicide model. The idea that quality improvement, that quality measures broadly, would drive improvement in the healthcare system, and that there was actually a theory and a structure that would help me understand how to do that. Perhaps most influential of all, though, David Covington and Thomas Insel. I heard David across many presentations, across many conferences that I was lucky enough to attend with him. And this was the slide that I think really was tremendously influential for me, because it talked about how, as a healthcare system, when we put on a systems lens and when we actually want to do something together, we're pretty good at it. We're pretty good about tackling public health issues, things that at first seem intractable: stroke, AIDS, heart disease. These broad issues of mortality had come down through concerted effort, but not suicide, at least not suicide yet. And that was earth-shattering for me to hear David say that. Really, really influential, and stuck with me to this day. Julie Goldstein-Grummett, Brian Almendering, Ed Coffey, so many people had shown versions of this slide. And this one appealed to me because it really was a theory. It was a structure that I could hang on to, that I could teach, that I could implement. Something that was based in quality improvement and prevention, a language that I was familiar with from my healthcare leadership studies, was now being brought into suicide prevention. It was really an opportunity of marrying these worlds. The Swiss cheese construct, that aligning these interventions in such a way that one after another would appropriately intervene to prevent a suicide death, became a real rallying point for us in Ontario, and a way that we could actually help influence people who are uncertain about zero suicide, people who were worried about what it meant or what the implications were really drawn to a slide like this, because I think it spoke to what we were trying to achieve and how we would thus go about doing so. But perhaps most influential was the clinical cases that we were seeing. And this is Aisha. Now, Aisha is not a real person. It's an amalgamation of a number of different stories to prevent identification of any one individual. But Aisha became a real rallying point and a clarion call as we were pulling together our systems of care. And as those systems of care would understandably struggle to try to understand how not to point fingers at one another, how to say, actually, it's the school's problem. Well, no, the schools would think it's the hospital's problem, or the hospitals would think it was the government's problem. Everybody would have an opinion about what was going on. But when we actually were able to come up around a person, a family, it became impossible to turn away. And Aisha's journey through the healthcare system, again, an amalgamation of real people's journeys, was illustrative of that. Aisha died by suicide at age 14, but prior to her death, she had touched many opportunities for intervention. The interventions were delayed, they were put on wait lists. Many people interacted with her with the best spirit of things, but ultimately it was not successful. And it was not successful because it was happening in a siloed fashion. It was happening as individuals. It was not happening at a systems level. And that was the key point that started off our journey for what we titled initially Project Zero and has now become Project Now. Project Zero was underlined by 5 key points. The belief that in our region, it is possible to achieve zero suicide, a zero incidence of death for our children and for our youth. Importantly, critically, it was necessary to co-design that project with the children, youth, and the families themselves, the people that knew best what was working in the system and what wasn't working in the system. This perhaps was one of the things that I insisted on the most throughout the journey, was we were not going to do this as just organizations. We were not going to do this as regions. We were not going to just do this as hospitals. We were going to do it as partners, and the involvement of families, the involvement of children and youth themselves, not tokenistically, but as genuine decision makers, as genuine partners, has been a critical factor right from the beginning. Of course, designing an evidence-based best practice solution, zero suicide itself, and through the efforts of Julie and her colleagues at the Zero Suicide Institute, it was really helpful to know, again, that these theories had been tested, that these teachings were there. We weren't necessarily having to recreate the wheel, but we were going to work on implementation. We were going to work on action research, and we were going to use the science to bring together things in a particular fashion that was successful. We believed in a radical redesigned approach. And importantly, along those lines, that no one individual, that no one partner could do it alone. And we believe, of course, in the idea that program evaluation, that ongoing quality improvement lens was necessary so that we could continue to evaluate, to modify, and expand. The region of Peel, our local region, our school boards, our community first agency, Peel Children's Center, now rebranded as EveryMind, our Ontario government, and our hospital Trillium Health Partners all came together to be the 5 founding partners of this initiative. But really, I've always felt that there should be a 6th insignia here, blank, for insert logo here, so to speak, because although these were the 5 founding partners, the partnership really was for all people to be involved in this region. And the notion was that it was only in working together that we could achieve something different, because suicide, as you well know, is not a simple problem. It's not even a complicated problem. It's a complex one, and it requires systems thinking approaches. That's why it has to be a healthcare priority, because it is not possible to achieve at the individual level. It's only something that can be successful because of cross-sector strategies, where we design systems around our children and our youth across, as we feel, 3 circles of care: our school systems, our communities, and our hospitals. And really, this was a partnership trying to weave a single thread through those multiple sectors in a way that hadn't been done before. We studied, we looked, we learned, we spoke to, we read, and we researched a lot of places that had been implementing a zero suicide strategy or something similar to it. And this by no means is a comprehensive listing of the organizations that have been successful so far. But it was one of the things in our scoping reviews that we were able to really put down, publish to our partners to build that evidence base of this is an implementation that has been successful in other places. We're going to learn from that. We're going to build on it and broaden it into scale to make it successful here. This became our strategy placement. The notion that there were really 3 key pillars. Again, the power of storytelling, the power of 3s. Here were the things that we were going to work on. Hope, fostering hope and resiliency through awareness, prevention, and identification. Help, coordinating access and care options for children, for youth, and for their families. And healing, building those promotions that talk about learning and talk about the understanding of suicide. Not, again, just doing it at one organization, not even doing it at a partnership of multiple organizations, but doing it across a region. Because Peel Region, one of the most ethnically and socioeconomically diverse areas within the nation of Canada, if we could do it here, we knew that we could do it anywhere in the country. So it became a living laboratory approach to suicide prevention. Our proposed initiatives and our current initiatives really followed the basic tenets of primary, secondary, and tertiary prevention. Again, not rocket science, but learning about what works and then applying an implementation science approach to driving that forward. In the primary prevention, it was about social media awareness, suicide prevention awareness, human-centered engagement opportunities in the school systems. Not to be kind of coldly clinical about it, but the notion that if we could invest in our kids in school now, perhaps they wouldn't need us clinically 5 years from now, 10 years from now. They wouldn't be coming to our emergency departments because we would have, quote, grown and educated a healthier generation. The secondary prevention approaches were about building up the resources, bringing new treatment opportunities, expanding treatment options in the community, family counseling and support, culturally sensitive training specific to mental health, because within a stone's throw of my hospital, there are 150 languages often spoken. That is immensely intimidating at first blush, but rich and resourceful the more you think about it. Again, harnessing the power of those approaches and the concepts and the energy that is in our communities became critical. And standardizing that. And if you think about my earlier comment about reducing variation, it's that notion of applying standard suicide screening tools and crisis planning tools across all the individuals and organizations that were working in this field. And finally, on the tertiary prevention side, what were we going to do in the hospital sector itself? We were going to bump up our intensive treatment resources. We were going to do systems pathway mapping. We were going to do educational modules that were accredited at the university for our professionals so that they could learn and do this. But ultimately, we're going to drive better treatment and more accessible treatment. And then we went out and started fundraising. We were initially granted seed funding from some very generous individual donors. About $500,000 initially started this process. And then a transformational donor, the WB Foundation in Ontario, gave $3 million to Aisha's cause. And Project Now was announced shortly thereafter. When the government of Ontario came on board with matching funds, individual funding, transformational donor funding, matching government funding became a reinforcing circle of how our programs became funded and our approach transformed. Throughout September of 2019 into March of 2020, much energy was going into the planning of that. And then our COVID pandemic hit, and our project was paused because Trillium Health Partners, Everymind, our public health partners all became focused on the pandemic itself. In September of 2022, post-pandemic, we've relaunched and we've secured that government funding once again, $3 million government matching the initial WB Foundation grants. And that has then subsequently been added to by another transformational grant from our Longo's grocery chain partners. $3.5 million came in, not necessarily only for Project Now, but for Project Now and for a broader mental health and addictions redesign effort. And that redesign effort is really, I think, where we have landed contemporarily so. Because for me, Project Now and Zero Suicide were ways of transforming the mental health and addiction system. If we could focus on eliminating the worst case failure in mental health, to quote Mike Hogan, then everything would improve. Schizophrenia care would improve. Anxiety care would improve. Depression care would improve, because we were improving transdiagnostically the pathways of the system itself, which admittedly were Byzantine and complex. We were simplifying them, and that was going to better all, driven by the notion of zero suicide. Throughout the pandemic and throughout our restart, we focused on that diagnostic and screening tool standardization approach so that the community and our hospital partners would be talking the same language, would be measuring the same things. We focused on improving our skill sets, dialectical behavioral therapy for all, a number of other evidence-based approaches have been brought into the region. We're focusing on urgent care clinics. We're focusing on actually targeting numbers, reducing the Peel Children's Center / Everymind waitlist by adding new service, 20,000 more hours of service of DBT-based initiatives was our commitment to our government partners. Expanding telehealth services, the utilization of mobile technologies, things that we were doing in a scattered approach pre-pandemic, became expert at during the pandemic, driven by some of the pandemic changes. This is now what we would bring forward for zero suicide approach. And finally, in concluding in our wrap up, I wanted to emphasize the answer to that question again. Why should this be a priority? Why should zero suicide be a priority of the healthcare system generally? Because it needs to be. Again, it cannot be something that's achieved at the level of the individual clinician. As you've seen, as you know, individual clinicians make these heroic efforts every day. It's only when collaboration is focused on the organizations themselves, on the regions themselves, on the system itself, that we can be successful. And we wanted to take our zero suicide learnings and apply them across sectors and across the systems, not just applying them at Trillium Health Partners, not just applying them at everyone, not just applying them in the school system, but bringing together everything and doing it all. Because that became one of the big reasons that we could work through the hesitations and the fears that often came up at the individual level when we spoke about zero suicide. Oh, we can't talk about that. You can't use the word zero. Oh my God, what if we are not successful? How are we going to cope with that? You can't tell me zero is possible. All of these things I have heard, all of these things I've been challenged with in debates and public systems, feedback that I've received. And my answer to all of those doubts, to all of those hesitations, to all of those fears is yes, we can. And we can only do it when we do it together. Hope, healing, help, having the courage to listen, to understand, to be authentic, to be genuine, and to build and co-create together. These are the things that are required. Doing it broadly, doing it at the systems level, holding ourselves accountable. Because it's together that we can commit to be a force of change in our partnership, in our organizations, in our communities, and in our individual lives. Ultimately, zero is the only number that counts. I wasn't going to be satisfied with a 10% reduction. I couldn't ethically be okay with a 22% reduction. It's only in focusing for perfection that I could feel like we were actually designing the system for better. And I hope that helps you work through some of the concerns or some of the questions that you may have about zero suicide. Is it possible? Yes, it's been done. Can I do it in my local place? Yes, you can. But do it as a partnership. Do it as a collection. Do not tackle it as an individual. Is it worth it? For sure. Can it be delayed by unforeseen things like global pandemics? Of course it can. But the idea is sound, and the structures and the work that you will achieve by coming together as a partnership holds over time. We are so delighted to have our band back together again post-pandemic and to be restarting this work. It's thrilling to talk to you about it today. It'll be thrilling to engage with you as a global institute and as a global audience over the next 10 years as we work to eliminate suicide and achieve zero in our region. We're thrilled to do it together. Thank you so much. It's been a pleasure to talk to you today.
Welcome to the Gold Coast Mental Health and Specialist Services Gold Coast Zero Suicide Lessons Learned from Australia's first mental health service to implement zero suicide. And today, it's my pleasure to want to talk to you about why suicide prevention must be a priority in healthcare. Before I do that, I'd just like to acknowledge the traditional custodians of the land for which I'm speaking for you today, the Hogan speaking people of the Gold Coast, Australia. I pay my respects to elders past, present and emerging. I want to pay tribute to Aboriginal and Torres Strait Islanders' unique values, their ancient and enduring cultures, which deepen and enrich the life of our community. I'd also like to acknowledge those that are impacted by suicide. Suicide is an emotive subject. I'm going to be exploring issues that directly relate to suicide from a clinician's and a systems perspective today, and endeavour to do this sensitively and respectfully. And I'd like to acknowledge audience members who have been exposed to suicide both professionally and personally. It's important to be mindful of your own reactions today, look after yourself while we work through some of the material. reach out for your support networks if you need to. So today, I really do want to acknowledge the collaboration and partnerships that we've formed over the last 8 years, in particular Dr. Sean Shea with the chronological assessment of suicide events, Professor Sidney Decker with restorative just culture, the late great Professor Barbara Stanley and her colleague Gregory Brown for safety planning intervention, Professor Tony Pisani, Daniel Murray and Morton Silverman for the prevention orientated risk formulation, Griffith University, Queensland and Queensland Centre for Mental Health Learning, and Queensland Mental Health Branch, the Gold Coast Primary Health Network, Mersey Care and NHS Wayback Support Service, the Life Framework, and Bond University. A little bit about Gold Coast. So Gold Coast, Queensland, Australia. We estimate population around 600,000. We're serviced by 2 major hospitals, the Gold Coast University Hospital and Robina Hospital. Now, here's the thing. We had upwards of 10,000 mental health presentations to our emergency departments in 2020. We average around 3,300 crisis calls per month to our service. A number of admissions per year is pretty stable, around 1,500. And we have had 7,500 consumers on our suicide prevention pathway. So the worrying thing about the 10,000 is approximately 70% of those that present are suicide related. So last 8 years, we underwent some major reform in suicide prevention. In 2015, we undertook a review of suicide prevention frameworks from across OECD countries. The goal to review existing suicide prevention paradigms and identify a suicide prevention evidence-based framework for our own service. During this research, we identified that the most innovative contemporary suicide prevention programs didn't rely simply on skills, policy, procedures, or pathways, but that a culture and system changes were common components of the frameworks that underpinned these programs. Some of the key findings from our research was having a consistent, standardized application approach had seen significant reduction in suicide of consumers under care, and a suicide prevention framework provided a shared understanding of the cultural issues and agreement about expected pathways of care. So we adopted the Zero Suicide Framework, and we're focused on those 7 essential elements of leadership, training, identify, engage, treat, transition, and improve. We developed a new way in which we reviewed suspected suicides within our service, utilising a restorative just culture principles. When it came to training, we re-looked at the training. We wanted to give the clinicians the right tools to do the right job. We developed an online modules as well as one-day face-to-face component for all clinical staff. We made it mandatory. When it comes to systemically identify and assess suicide risk among people receiving the care, we developed a standardized clinical pathway for people with suicide risk. And this has subsequently been adopted statewide and across other jurisdictions in Australia. The way that our consumers were transitioning from our services, we partnered with the PHN, our primary health network, and we have a transition program in place up to 12 weeks called the Wayback Support Service that helps transition people back into the community post our crisis follow-up. We invested quite heavily in the evaluation and research, and I'm going to talk a bit about some of the outcomes on that research later on. But fidelity monitoring and the application of the suicide prevention pathway was an essential element as well. I do get asked this question, suicide prevention reform and change management, why is it so important? Why now? And yet so challenging in healthcare environments? Well, I think the answer is as clinical professionals, we excel in finding solutions in patient care. We are solution focused and we are highly motivated to effect improvements in care, but we tend to fall short when it comes to implementing and evaluating these initiatives, often because we don't have the skill set to effect change, and it does require a completely different skill set for change management. If we add to that, I think this statement sort of sums this up. Healthcare is filled with moral injury because you're constantly failing. You want to help people, but often the system isn't built to do that. When it comes to leadership, change management takes into account the various barriers to success, but when done properly, it lays out a step-by-step process to identify a challenge, ensures the diagnostics are accurate so you focus on the right issues to meet your goals. It's not as easy as it sounds. Good change management means leaders identify the correct problems that need to be solved before they even start. This means as leaders, we need to be brave enough to take a hard look and often a critical look at our systems and our processes and be able to articulate what the gaps are and what we need to change. It's not about maintaining the status quo. It doesn't have to cost a fortune either. So the first stage for any reform is developing a case for change. And that's what I want to talk to you about today. I want to talk about developing a case for change for people who work with suicide risk regular basis. And it's about acknowledging the complexities and the barriers to suicide care. So I'm going to talk about risk categorization briefly, the impacts on clinicians, identifying suicide risk, risk management planning, risk formulation, addressing the drivers, our own suicide prevention pathway, and a little bit about our research and evaluation. So first, let's look at risk categorization. And I thought this false hope or rationalizing our unconscious. You see, the last 50 years, there's a major onus on clinicians to be able to predict future human behavior like suicide and assign people into categories as high, medium, or low. And our systems and processes and tools have been built around the expectation that as clinicians, we should and could accurately predict risk. And many clinicians believe they've become quite skilled at this. Categorization of risk is often the focus of acute assessment in itself, and the belief that categorization would identify most of those people that are in need and that could be managed by others as well in the community, such as service providers, including general practitioners. Yet the data tells us that most people who die by suicide and assessed by mental health services were categorized low risk just prior to their death. Yet we know that risk factors and warning signs are actuarial in nature, and they're based on broad population statistics used to predict risk in an individual. But here's the thing. There is a significant margin of error between assessing group and individual risk. Psychiatry identified that this margin of error as being so high as to render the risk estimates on individuals as being virtually useless. The thing is, if we would be right most of the time if we predicted low risk every time we assess someone, but not because it was an accurate prediction, but because the vast majority of individuals who think about suicide will not attempt suicide, and even fewer will die by suicide. The ratio of attempted suicide to death by suicide is approximately 30-1 in Australia, and a significant number of people seriously try to end their life by suicide, but only a small comparative number do. Yet we've been asked to predict whether a person will or will not go on to end their life based on actuarial risk factors, despite there being little or no empirically supported evidence that we can accurately predict future human behaviour, especially suicide, and a lack of definitive guidance on how to actually help people with suicide risk. Yet that's what we've been asked to do. That has been the focus and that has been the training. Weigh up the risk factors and protective factors equals a level of care. Often our training is focused on assessment and categorization, not how to help, not how to intervene for a person in suicide crisis. Yet the evidence has been pointing the other way for the last 20 years or so. The research tells us risk stratification cannot predict suicide outcomes, should not be used to allocate resources. Queensland study reported 68 SAT1 suicide between 2014 and 16, demonstrated that of those, 70% had a formal risk assessment. Nil had been identified as high risk, 75% had been classified as low risk. Suicide risk assessment is not a prediction of suicide or suicide behaviour. It's not a calculation of a single or final score or category based on population-based statistics. And there's many more research to support that. But our psychiatrists in training typically learn that assessments of suicide risk should culminate in a probability judgment expressed as low, moderate, or high. But this way of formulating risk has predominated in psychiatric education and practice, despite there being little evidence for its validity, reliability, or its utility. Add to this, the general guidance exists on how clinical and actuarial-based knowledge should be integrated or what the outcome should be given a particular assessment of risk. So why are we excluding risk as clinicians? Well, the majority of people that die by suicide have been categorised as lower risk, so they make up more of the suicides. As clinicians, we can become desensitised to risk. Most people who come through our emergency departments will be significantly higher risk than the general population, but we become habituated and desensitised to this. There's also a pressure to label someone as low risk if the decision is to discharge them. And one view is that the pressure arises because hospital and organisations hope to protect themselves from criticism or legal action should an adverse outcome occur. Static statements of risks do not necessarily reflect the highly changeable nature of suicide risk. We have to acknowledge that suicide ideation intent is fluid and fluctuates, as the person may have been identified as low risk at the point of discharge, but a range of events can occur rapidly and escalate the risk and their ideation intent. All this cognitive sensitization. This occurs when one undergoes a provocative experience and subsequently images and thoughts about that experience become more accessible and easily triggered. It's applied to suicidality. As suicide experience accumulates, suicide-related conditions and behaviours may become more accessible and more active. The more accessible and active these thoughts and behaviours become, the more easily they are triggered, even in the absence of negative events, and the more severe are the subsequent suicide episodes. So as episodes of suicidality increase, their relation to external triggers decreases and their severity increases. So acknowledging this statement, the categorization of suicide risk is only as good as the moment in time the assessment took place, not 1 minute after. And this doesn't even allow for the minimization statements that people in suicide crisis often make. Categorization does not acknowledge the fluctuation of suicide conditions that we all know can occur. People categorized as low risk will often not have a thorough risk management plan in place, due in part to a lower level of concern due to categorization. However, acknowledging that a person will be suicidal again, regardless of the assessment, enables preemptive risk management planning to take place. We also see clinicians experience multiple false positives following assessment. We see clinicians becoming defensive or have a sense of pessimism and often nihilism. You could never have predicted this. It was just a cry for help. It was inevitable. If they really wanted to do it, or even a sense of hopelessness. Well, there's nothing we can do. Well, I don't know how to help this person. And we often see risk exclusion. Deny suicide, no intent, no plan. They weren't suicidal when I saw them. Or suicide in the context of alcohol, or they're chronically suicidal. But the anxiety, fear, and trauma experienced by clinicians following the death of a consumer cannot be underestimated. If the clinician does not receive the right support from the organisation, we may see an imbalance between the alarmist and dismissive positions, which impact negatively on clinical care. We often see unchecked countertransference, with the impact often resulting in traumatised staff focused on risk exclusion rather than identification. Unchecked countertransference, we care so much that the emotive feelings of helplessness that can emerge can evoke internal defences to counteract those uncomfortable feelings. We subconsciously create those defences against these feelings, project these defences as negative, subjective statements. It was just a cry for help, they were intoxicated, they're after secondary gain, they have personality vulnerabilities or borderline personality disorder. We want to help, but if we leave counter-transference feelings unchecked, we risk minimising the consumer's risk and care. Use of language has the power to influence care. Research on Australian ED nurses found that attitudes towards individuals presenting with self-inflicted injuries were influenced by their perceptions of their ability to effectively respond. So we have to acknowledge that basing an assessment on accumulation of actuarial risk factors alone is not realistic. Suicide risk assessment tools have a very low predictive value, and a risk assessment tool that accurately predicts suicide does not exist. Now, assigning risk as low, moderate or high is arbitrary, and assigning people into categories is not predictive of future suicidal behaviour. So removing risk categorisation removes one of the key barriers to helping people who present with suicide risk. We're moving away from prediction to intervention. We have to acknowledge that our role has changed. We now focus on addressing the drivers for suicide, intervening and risk management through the crisis period. Let's look at a case for change for suicide and the impact on clinicians. Clinicians working in the complex world of mental health and suicide prevention face many challenges, and one of those is the devastating impact of the loss of a consumer. We work in a complex system where complexities are not overtly acknowledged or reconciled within our responses to critical incidents such as suicide. As mental health workers, we have significant exposure to consumers who die by suicide. It's estimated on average a mental health nurse working full-time experiences a consumer die by suicide every 2.5 years. The death of a consumer due to suicide frequently results in mental health staff experiencing a range of adverse outcomes. There can be physical symptoms that include fatigue, insomnia, nausea. Psychological symptoms can include disappointment, self-blame, anger, guilt, shame, troubling memories, and anxiety. It's one of the very few topics that almost uniformly triggers anxiety and apprehension in clinicians, from both novice students to seasoned practitioners. Often in mental health care, there's a culture of blame that often exists around the events such as suicide. This is often exacerbated by political forces and criticism from public agencies and the media, and often there's a cascade effect within organisations from the top down. And we often see changes to clinical treatment, often driven by high levels of risk aversity, that's potentially harmful to consumers as well as with mental health services. As mental health services, we often use errors as markers of performance at individual, team, or system level, and often classified as preventable or not. But we know that suicide is an extremely complex phenomenon, yet we continue to use linear processes to view such a complex event. Often the result being little impact on risk and safety, and often an unrealistic expectation for staff, and there's limited learnings. Some problems with the way that suicide deaths are reviewed. We have an over-reliance on incident reporting as a safety tool. Analysis of RCA reports found that most investigation recommendations are limited in scope, not robust enough, and are not likely to be effective. And findings often not shared across the system or even back to the team involved. Rates of adverse events appear to have been static for the past 50 years. So we have to acknowledge that we only provide a snapshot of activity or what went wrong and use that information to improve a complex organisational systems which are clearly not straightforward. Hindsight bias is a complex issue that routinely impacts our incident analysis as well, and reviews are aware of the outcome tend to overestimate its likelihood and the ability of the clinician to have predicted it. And this tends to colour the evaluation of the actions taken prior to an outcome. Actions before a good outcome must have been good. Actions prior to a bad outcome must have been bad. This is also the case when we allow outcome bias, the severity of the outcome or the level of harm to drive its response to an event. So our previous review systems revolved around outcome bias, focusing predominantly on events with the worst outcomes. So in addition to the sense of injustice this may create, it allows unsafe actions which do not lead to an adverse outcome to go unexamined and therefore contributing to the persistence of an unsafe system. Workplaces with cultures of blame are often associated with negative patient and staff safety. We see workplaces that are bureaucratic, where failures are considered isolated, systematic reforms are avoided, and new ideas are seen as being problematic, or pathological, where punishment and covering up of errors and failures are pervasive and new ideas are discouraged. Obviously, the aim is high reliability healthcare, where workplaces recognise how safety can be improved and is rewarded. Restorative just cultural literature identifies these three faces of victim. Of course, first there's a patient, family, and carers, but the second victim is the health professional directly involved in the event. The third being the health organisation, other patients, and colleagues. And what we see, the researchers identified that the second victim feels that sense of shame and blame can lead to burnout, decrease in subsequent care and compassion, which could lead to more errors, safety, and operational impacts. The literature recommends that hospitals interested in limiting the negative effects of second victim experiences may benefit from reducing punitive responses to errors, encouraging supportive responses as healthcare providers cope with their involvement in patient safety, and adopting a restorative just culture process for incident reviews that seeks to achieve a balance between ensuring learning from adverse events and the accountability of staff. So it's a move away from backward-looking accountability to forward-looking accountability, which explores the impacts and needs that result from an incident and the obligation this puts on stakeholders to improve safety according to roles and responsibilities. It's really about getting to the account of failure that can do two things at the same time: satisfy the demands for accountability and contribute to learning and improvement. Let's look at the case of change for identifying suicide risk. Again, we've often used diagnosis as a gateway to treatment, and yet many people who die by suicide do not necessarily have a serious mental illness or access one diagnosis. Our clinical processes have in the past been engineered around the idea that we can predict risk and our job was to find mental illness and treat that. Traditionally, there's been a strong focus on assessment as an end in itself, and often a lack of integration of training to support local pathways. Add to this, many clinicians feel comfortable excluding risk rather than identifying risk. And also add to this their values, attitudes and beliefs, projection and unchecked counter-transference that can occur. Some of the challenges we often face is that many people minimize their suicidality. Many people see no hope or relief from their suffering and so little incentive to relay suicidal ideation to clinicians. Even if their ambivalence about attempting suicide has led them to voluntarily present to our service, they're going to be quite cautious about revealing the full truth. For the greater part, they may still want to die. And they're predisposed to share just some of their ideation and actions while hiding their real intent or method of choice. The patient needs to feel safe in order to disclose this information. So why is it that people experiencing suicidal intent may be hesitant to openly share? Well, the impulsive patient may lack extensive ideation before his or her attempt. They may be purposely withholding their method of choice. They don't want to be thwarted. It can be seen as a sign of a weakness, a sin, or a shame, taboo. They're worried that a clinician will perceive them as crazy, and they fear that they're going to be locked up during a crisis, or the patient doesn't believe that anyone can help. Also acknowledge that a person in crisis feeling a sense of thwarted belongingness and connectedness, engaging with a compassionate and caring doctors and nurses is likely to be having those needs met at the time of engagement and assessment. So they are also unlikely to be feeling suicidal at that moment in time the clinician assesses for suicide risk, but not because they're no longer suicidal. So it's sometimes easy to believe that if we ask directly about suicide, the patient will answer directly and truthfully, but this does not seem to be the case. From a psychodynamic perspective, curious paradox can arise. If a patient believes that suicide is a sign of weakness or a sin, unconscious defense mechanisms such as denial, repression, rationalization, or intellectualization may create the conscious belief that the patient is much less than it actually is. So when asked directly about suicidal intent, this patient may provide a gross underestimate of their intent, even though they're genuinely trying to answer the question honestly. From a phenological perspective, some patients may relay their intent in stages. Whether evaluating such consumers in ED or a crisis line, one would expect that the consumer would share some information, see how the clinician responds, and then share some more information and reevaluate where the session's going. So patients are going to withhold a lot of information until they feel comfortable and safe enough to be able to share what's really going on for them. And at this point, they may feel safe enough to share the full truth with the clinician. Add to this transference of the patient as carer dynamic that can happen. We know people in crisis are very hypervigilant, observing our every reaction and action. And if we are slightly tentative about asking about suicide, if we minimize the use of the word suicide to self-harming or not being around anymore, the patient may want to make us feel comfortable. They may try their best to answer questions that will please us in some way. We have to acknowledge that not all patients will openly communicate their intent even when asked, and even in cases where their life or death ambivalence has led them to voluntarily present to ED. The fact is the majority of people who die by suicide denied intent when last asked prior to their death. We have to cease this normative approach to suicide risk assessment, which erroneously relies on an individual's communicated intent. We have to acknowledge that the clinical assumption that the absence of communicated explicit intent is synonymous with nil suicide risk, which is inherently flawed. We need to get beyond the deny suicide, no intent, no plan, because it doesn't mean that they're not suicidal. We know most people minimize their suicidality and thoughts and fluctuate and are often dynamic. It doesn't mean they don't have a plan. We know that everyone who's suicidal has thought about a method, how they would do it, not necessarily a plan. Exploring planning comes later. It doesn't mean that they do not have intent because risk fluctuates. So this statement means we don't really know, and we have to stop using it to determine modality and levels of care and risk. This is where Dr. Sean Shea's wonderful work with the chronological assessment of suicide events comes in. We need to get beyond that stated intent. And I think Dave Jones sums this up nicely for the case approach. The case approach moves the clinician almost imperceptibly into the secret internal workings of the mind and soul of the patient, tormented by ideation. I believe the case approach is a remarkable conceptual clinical contribution to the field of suicidology. It should be routinely taught to any frontline clinician, and it has the power to meaningfully save lives. CASE was developed to explore the patient's inner pain and suicidal planning that often reflects the pain. It helps to overcome hindrances that block the open sharing of intent. Shea believed that errors in suicide assessment do not stem from poor clinical decision-making, but they result from a good clinical decision, often from a bad database. Most frequently, distorted or missing information relates to the extent of the patient's suicidal history planning intent. Shea developed validity questioning techniques, which are used throughout the CASE approach and emphasize not only the impacts of what we ask, but how we ask it. The macrostructure of the CASE is about avoiding errors of omission. Errors of omission increase with increasing levels of required data, decrease when split into smaller, well-defined regions. It's a simplified interview format, easily learned, hard to forget, and provides a reliable interview strategy no matter how under pressure the clinician may feel. Let's do a case for change for standardized risk management planning. For many of you that have worked in crisis, in emergency departments, and particularly in the early hours, would know that feeling, fingers crossed, because there is an expectation that clinicians are competent in identifying and mitigating suicide risk. Yet again, the training offered has always focused on identification and exclusion, not identification and mitigation. With most people being categorized as low risk, many clinicians either lack experience, feel a sense of helplessness or confidence, develop a risk management plan. After all, if they're all deemed low risk, why would we be doing an intensive risk management plan? So this is often complicated by misunderstanding around prevention of access to lethal means, suicide risk fluctuations, and the traps where people deny suicide during assessment, as well as the workplace cultures and systems that support exclusion. We have to accept that despite what the consumer is telling us in a crisis situation, they're no longer suicidal, they will be suicidal again when they get home. And it might not be right away. It might be in the next week. It might be the minute they walk through their door, and it may be something unrelated to the crisis precipitant that triggers that thought. So before discharging a person home, we need to ask ourselves, what has changed? What have we done? What have we put in place to help prevent suicide now and for when the person gets home? And this is where the safety planning intervention preempts fluctuation. We know that problem-solving capacity diminishes during times of crisis, and overusing practicing a specific template can enhance this coping. It also helps with increasing engagement and follow-up. It acknowledges that suicide thoughts will return. It aims to build the resilience for consumers to be able to address the suicidal thoughts. It reminds consumers that there is a way through the crisis without death, and it ensures that known suicide methods have limited or no access. So restricted access to lethal means is a key component of the safety plan, a very important component, and we have standardized this as a collaborative process to involve family carers, focusing on 5 key actions. I think this kind of sums this up. Going out to buy medication or a rope will be way beyond capability while depressed, but having one near is another matter. So let's move away from the fingers crossed. We hope they will be okay to standardizing risk identification and collaborative risk management planning and collaborative prevention of access to lethal means. So how we synthesize and articulate risk information is extremely important. We've often see a variability of approaches to synthesizing assessment information. Sometimes formulations are arbitrary, often subjective, often focus on perceived weaknesses, not strengths, and focus on risk exclusion through categorization, not identification. Often there are no standardized approaches to formulation, and quality of the formulation relies on the experience of the clinician or the system that supports this practice. But we know that how we communicate a person's experience can often be emotive and subject to all those complexities and barriers we've talked about already, and people can experience during the assessment. It was Tony Pisani that said any issues that become more manageable when you have a framework for understanding and addressing it. And this is what the prevention-oriented risk formulation does. It really does help identify the risks and importantly the context of those risks. It helps articulate the person's strengths and their context, available resources, what we have to work with, internal and social strengths to support safety planning and treatment. It allows the mitigation of foreseeable risk changes we know will happen, changes that could quickly increase a person's risk state. It helps identify key areas for treatment planning, i.e. the drivers for suicide. It helps articulate risk and treatment modality, incorporates our own beliefs and judgment, and can be used by the novice to expert practitioner. Essentially, we all need to be speaking the same language when it comes to suicide risk. Getting the drivers for suicide. So much has been said about the identification of suicide and suicide risk, but it appears little of what to do to help a person through a suicide crisis. There's been something more than assessment and just risk management. We know CBT and DBT are most empirically most effective, but you often overlook the effectiveness of crisis intervention. A crisis intervention framework helps to address the drivers for suicide, can help reduce the intensity and connection to suicide, and change a person's perception that suicide is the only option they have. We have to acknowledge that suicide crisis is also an opportunity for change. It's an opportunity to collaborate. It's an opportunity to work with a person who's most susceptible to influence from targeted assistance during their crisis. And it's an opportune time to begin that partial resolution. And it's the consumer's perception of the precipitating event that is a crucial factor in commencing this resolution and mitigating this risk. We know the key to crisis resolution is the context in which we view an event or the perception that we have. And it's one area that can actually be changed. It's one area that can be disputed or challenged so that a crisis can be stabilised. And it is literally the first step towards a partial resolution. It's about creating that sense of doubt in the consumer's mind that their perception of the event which precipitated their crisis, perpetuated and influenced their behaviour, can be changed for the better. And it's about reframing their perception of events. So by helping a person to change the way that they see the event, you can overcome one of the first hurdles towards reaching resolution. So in summarise, what did we do within our service? And let's look at the suicide prevention pathway. We researched and identified the best way we could identify and assess suicide risk. And this is where the chronological assessment of suicide events comes in. How we pull and synthesise that information together, we use the prevention-orientated risk formulation. We standardised our risk management planning by using the Stanley and Brown adaptation of a safety plan, which includes standardising prevention of access to lethal means. We should provide a literacy pack for consumer and families, and we also do a rapid follow-up if we're discharged to the community within 48 hours, and we focus on addressing the drivers for suicide. We also have transitions of care up to 12 weeks post-discharge from our service. So is it working? Well, 8 years is a lot of hard work, and there's a fair bit of research there. Since 2016, over 7,500 consumers have been on the suicide prevention pathway. Just from this information, predominantly age groups that have been placed on the pathway are 18 to 24 years old. By sex, we have more females than we do males. So we looked at the suicide prevention pathway on repeated suicide attempts. So repeated suicide attempts within 7 days, 14 days, 30 days, and 90 days. And we found that placement on the suicide prevention pathway reduced risks of representation with suicide attempts at all time intervals. And the greatest efficacy at 7 to 14 days, which is the average length of SPP placement, which was 16 days. So 6 different models of time to event analysis showed that people on the SPP have less risk of representation within a given time period when compared to presentations not on the SPP. And the placement on SPP reduces the risk of a repeated suicide attempt by around 35%. The effect on repeated suicide attempts time to event analysis. So this being on the SPP had similar effects regardless of a person's age, their indigenous status, their diagnosis of personality disorder, or past suicide attempts. Indeed, placement on SPT was recommended for all suicide attempt presentations, but particularly persons with personality disorder and even first-time presenters. We did a 3-year rolling average since the launch in December 2016, and between 2017 and 20, 3-year rolling averages had reduced by 21.8%. So suicide prevention is everyone's business, but not everyone's business is the same. Reducing the rate and impact of suicide in communities is not something any single agency or level of government can do alone. It does require, as we all know, those upstream actions, community responses, cross-government, cross-sector, and societal change. However, health systems play a vital role in suicide prevention, particularly for the provision of specialised mental health and crisis care. We are often at the pointy end when it comes to suicide. We still have a long way to go, but we are optimistic. It's not easy to affect and maintain momentum and change within an organisation. There needs to be long-term commitment. It needs to be top-down, bottom-up approach. Leadership buy-in is essential, and that's from the board of the hospital down to the staff on the ground. We need to utilise the best approaches in clinical redesign and change management. This is an emotive subject. It's motive for many people, so we need to win hearts and minds within your organisation. Culture change is essential, as is embedding a restorative, just culture. It's not just another project. It is reform. It's going to take time, but utilising a zero framework helps to scaffold your approach. How would you start? We'll make an aspirational commitment to zero suicides. You will change the conversation. You will start the debate, and you will start with the why now. Start with your case for change and start reducing suicide. Just like to, on behalf of the Gold Coast Mental Health and Specialist Service, thank you all, and we're very happy to collaborate and support these services on their journey to zero suicide. Thank you.
Hello, I'm Joe Rafferty. I'm Chief Executive of Mersey NHS Foundation Trust and also Chair and Co-founder of the Zero Suicide Alliance for the United Kingdom. I want to talk through a 10-year journey, or about a 10-year journey, of adopting and implementing a zero suicide approach in Mersey Trust and building out from that into some of the work we've done with the Zero Suicide Alliance. As part of our journey in around 2014, Merseycare declared an ambition to eliminate deaths by suicide for any patient in our care, either as an inpatient or as a community patient of the service. Indeed, we explicitly wrote it into our strategy. Shortly after that, I met Steve Mellon, who had been recently bereaved by the death of his son by suicide, Edward Mellon, and we talked about the notion of bringing best practice into the whole business of suicide prevention inside a mental health facility. And from that was born the notion of the Zero Suicide Alliance. Shortly after meeting Steve, the then National Clinical Director for Mental Health, Geraldine Strathday, came on board. And finally, a brilliant communications director who already worked at Merseycare Trust, Elaine Derbyshire, also joined forces. And the four of us in 2017, with the blessing of the then Secretary of State for Health, Jeremy Hunt, launched the Zero Suicide Alliance. So in the next 15 minutes or so, I want to talk through some of the challenges, but definitely some of the benefits we've seen from adopting a zero suicide approach in care. Before talking any further about the specific work, it's useful maybe just to take this slide as an introduction to Merseycare. We're one of the biggest trusts of our type in the National Health Service in England. We provide a full range of mental health services from essentially social prescriptions and talking therapies through to one of 3 high secure services in the NHS. We also distinguish ourselves by having a very large physical healthcare in the community footprint, and this is providing us with an opportunity now to, in health service terms, really see the total person by integrating physical health with mental health, and increasingly thinking about the social health experience of people. So it provides us with a very large footprint. We cover a population, depending on the service, of about 1.4 million through to 1/3 of England. For high secure services, it covers about 11 million people. So we are an organisation that is complicated, diverse, large, and therefore a really significant challenge. Since launching the Zero Suicide movement, the trust itself has trebled in size. So we've been doing this work inside a very complex tapestry of change. One of the things we did, but at a very early stage, was establish what we call Mersey Care's 4 cornerstones, or 10 practices for zero suicide. We were very clear that zero suicide couldn't simply remain an esoteric or a narrative that wasn't accompanied by a set of practices. So we spent a long time as an organisation searching through best evidence practice and literature and so on, and we had 4 cornerstones about service user and partner engagement, safe, effective care and treatment, a competent workforce, and research and evaluation as a critical cornerstone. And you can see for each of those cornerstones we had a small number of practices. So areas where frontline staff would be deeply engaged in moving forward our systems, processes, and indeed our culture, as I'll talk about later, inside these 10 practices. So what I want to do today is talk a little bit about aspects, not all of these 10 practices, but aspects, probably 3 or 4 of these. The first is co-production with service users of materials and resources to aid self-care. So this is a screenshot of the Zero Suicide Alliance website, which features the sort of core training that the Alliance, with the input of Mersey Care, has produced as a national framework of training support, either for professionals, for lay members, or for organisations related to healthcare but not in healthcare, or indeed organisations that had experienced issues of suicidality with their workforce, etc. The training package, which I'd invite you to take a look at it if you're not familiar with it. In fact, there are 3 training packages. A full version takes 20 minutes, an awareness training session that takes 10 minutes, and a social isolation training, which is a sort of step-up module. So you can choose the point of entry into this training package. They're all digitally enabled. All of these packages are free. And the suicide awareness training, the full version, is based on a set of options appraisals where people can trial different approaches and see how that would have worked out, etc. And of course, over time, we've produced awareness training in different languages. We've produced it for different sectors, the university sector, taxi drivers, etc. Note that there's a prison edition, and I'll talk about some work in prison later. I set our Safe from Suicide team a task of producing training that could be done on any digital device, could be done in around 20 minutes, and the cost would be free to the public, but to the people providing the training, the ZSA and ourselves, would cost no more than a couple of United Kingdom pounds or a small number of dollars. And indeed, rather remarkably, they came back with exactly the blueprint for the model that you can now see on the website. Really importantly too, the Alliance has diversified, and you can see the sort of dashboard data here that covers all 4 of the United Kingdom's countries. And then in England, we have on the middle column, you can see the dashboards that cover the different regional areas. And then we've got some sector level dashboards. And this is the bit about putting into people's hands who have got some sort of ambition, either as a health service provider or indeed as an employer, the skills, tools, techniques to begin to create simple but evidence-based and data-orientated plans. So, I mean, the great news is, since we launched in the House of Commons, the UK Parliament in 2017, over 2.5 million people have now taken the training, which is just fantastic and brilliant that we see this number just continually rising all the time. A real testimony to, first of all, the need for this sort of approach, but secondly, we set out to be an accessible training package that ripped down the sort of stigma around suicide and suicide prevention, to begin to make it easy for colleague groups, interested parties, to begin to join the suicide prevention movement and move our agenda forward. And I think these 2.5 million people are a really sound asset for us now to have in our communities and our workspaces to push us towards that zero suicide notion. It's interesting too that zero suicide itself has been a contentious idea, but actually, and we've had it inside the Zero Suicide Alliance and people that we've worked on the training with. But we've always been of the view, if it's contentious, not harmful, but contentious, then it's good that people are talking about it. We're actually getting it into the narrative. But one of the things I want to show you now is some initial work when we looked at the co-produced awareness training. This is right at the start of our training work, but when we ask before and after questions of nearly 3,000 members of staff at Merseycare, you can see the professional breakdown and the sort of corporate or non-professional teams in the organisation. We ask two questions: is suicide a selfish act, and is suicide inevitable? And I'll just focus on the inevitability question for now. You can see a huge reduction in both categories, both the corporate teams and the professional teams. The before question, very high levels of sort of innate assumption, working assumption that suicide is inevitable. And you can see after the training, a 20-minute introduction on the training, you can see the inevitability question absolutely collapse. Not to zero, but to around 10% of all respondees. And I suppose that for me triggered a really fundamental mindset question. How can you prevent something if people think it's inevitable? So tackling this inevitability question has always been right at the core of Merseycare's and Zero Suicide Alliance's approach to having basic training that shifts the mindsets of people. This is evidence that culture and attitudinal culture can change after the Zero Suicide Alliance training, and that in itself is a very, very powerful impact of this piece. This is just a reflection again on our practices and milestones piece. And this is a piece now that I'd like to introduce around thinking about how we have standardised post-incident reviews and collect, analyse, disseminate data or near-miss data in a way that changes practices. And although this isn't fully a research and evaluation piece yet, this comes from our work in His Majesty's Prison, Liverpool, where Merseycare runs the mental health services in that organisation. Around April of 2018, those services have been run by different providers of care, and Merseycare took on the contract. There were significant issues with death by suicide in the prison. I'll show you some of the data in a minute. But what we decided to do was implement a zero suicide approach to mental health care of patients in the prison who were directly under the care of Merseycare. The next two slides show some of the initiatives introduced that have improved safety and experience for the mental health patient cohort. We absolutely prioritised safety through a safety huddle approach. We really stitched together tightly the notion of multidisciplinary teams. We changed to begin to look at bereavement by suicide or other predisposers that may well have caused real vulnerability in those early few days in prison. We prioritised top 10 meetings, so the 10 most complicated people we thought who were in the care of the trust. We talked about them and talked about them in detail. And on the next slide, we just continue to look at some of the issues which we thought if we introduced these sorts of approaches, disciplines, policies, care program approaches, etc., and we integrated as much as this is possible, our hypothesis is we would see a change in suicide behaviour in the prison. So I'm just very quickly going to show you the change in the average numbers of suicides per year. That's in a set period. Before in blue and after introducing Zero Suicide Alliance methodology and plans. So you can see there's an average over a 3-year period in 2015 to 2018 of about 4.5 on average suicides per year. Subsequently, in October 18 to October 2022, you can see that that number is on average half, which is a really, really significant reduction in deaths over the time period. So this is work that we're working through to publication, but a really strong indication that the ZSA methodologies and plans and the zero suicide philosophy can have a fundamental change on suicidality, in this instance in a prison setting. So a lot of this work, that's 2 examples of how I think we've done some really great work. There are many, many, many more. But one of the things that escaped us for the first few years of this was understanding that psychological safety to create the types of changes we wanted to do was absolutely and fundamentally important. So we introduced a restorative, just and learning culture approach to the organisation. A culture that accepts nobody's account as true or right and somebody else's account as fundamentally wrong. But it accepts the value of multiple perspectives and uses them to encourage both accountability and learning. You can see the sort of conditions and characteristics of a restorative just culture on the right, and indeed you can read quite a bit about it in a book that we published just last year. But if I look now at the impact of doing this work, you look on the left-hand side here, where we looked at investigations and suspensions as a result of very serious incidents in the organisation. You can see that investigations have decreased by 71%. Suspensions have decreased by 89%. And at the same time, we've increased our workforce by 130% as the organisation has grown. If you look on the right-hand side, staff feeling safer and raising concerns, you can see all of the acquisition work we've done there with the downward arrows. But what this also demonstrates is an upward trend in answering the question, I would feel secure raising concerns about unsafe clinical practices. So if you think that we want our staff in complex safety situations to feel psychologically safe, to ask questions, to raise concerns, to talk to senior leadership about the need for resources, etc., you need a psychologically safe environment. And I think we're probably the first NHS organisation, certainly probably the most comprehensive piece of work done in any healthcare provider, showing that if you create this psychological safe space by demonstrating that people are able to engage in learning cycles rather than in cycles of HR-related activity, that you drive up the staff's general ability to speak freely. And I firmly believe there's a strong connection between us learning from significant healthcare events like suicides in care and our ability to learn. So we need to be predisposed to this sort of approach. Second last slide then. So this slide demonstrates that psychological safety has an impact on improved performance in wicked areas such as suicide. This is evidence produced by the National Confidential Inquiry into Suicide and Safety in Mental Health. You can see the 10 things on the right-hand side that this group, led by Lewis Appleby and Nav Kapoor, suggests needs to take place. We've been implementing many of these, and some of them we've talked about. The orange line shows the median rate of suicide for the NHS mental health trusts across the whole of the NHS, and the blue line shows the Mersey Care specific line. You can see the box too, where we've begun to introduce the zero suicide thinking into Mersey Care. And I think it's interesting that since we've introduced that, we've seen a bigger difference between the Mersey Care number and the national median number over time. So, you know, a sort of indication that this type of thinking creates improved benefit. So, last few reflections. We've given just a snapshot of our work. There's a lot more. But adopting zero has made us much more curious about what we do and how indeed we do things. It's allowed us to disagree constructively, but in a solutions-focused way. That's made us in turn more ambitious for patients and created greater examples of lived and professional experience actually synergizing to bring these changes to place. And it's created the first and most comprehensive demonstration of the power of restorative just culture to unlock psychological safety as a cornerstone of a true learning system. So that's a quick run through of some, by no means all of the things we've been doing over the last 10 years. Thank you for listening, and thanks to our wider Mersey Care family and our Zero Suicide family for making this happen.
Hello, it is good to be with you today. I am Mike Hogan. I spent 25 years trying to run state mental health systems in the United States, in Connecticut, Ohio, and then New York, and did tours of duty on the boards of the National Institute on Mental Health and the Joint Commission, and had the honor of chairing President George Bush's New Freedom Commission on mental health. I came late to this challenge of suicide prevention, but I came because of deep frustration at how poorly we were doing. In the years since the first national strategy for suicide prevention in the United States, we had seen a lot of tools developed, but rates continue to go up. And increasingly, I was concerned about the very poor results we were getting in healthcare, where I felt we should be doing better. Instead, people were not detected with suicidal intensity in primary care. The behavioral health system, where people are often sent when they're suicidal, is one where none of the professions require competence in working with suicidal people as a condition of licensure. We don't focus on it very well, except largely through policies of containment, such as hospitalization. And the rates of death remain too high. At least a quarter of those who die by suicide are in the behavioral health sector of care at the time of their death, when they ought to be getting the support they need to do better. So I was very frustrated at this turn of events, but I'd had experience in implementing and disseminating evidence-based practices in behavioral health and knew that that was possible, and was motivated by the fact that 10 to 15 years ago, a lot of evidence was starting to emerge about the effectiveness of approaches to detecting suicidality, supporting people with suicidality, directly treating suicidality, and helping people turn the corner and recover. We were also impressed by the extraordinary experiences at the Henry Ford Health System, which established suicide prevention as a core goal of its Perfect Depression program and achieved quite remarkable results after dedicating itself to that goal. So change was possible. I would also have to say that we were encouraged by the emerging strong voices of people with lived experiences who had experienced what Eduardo Vega calls suicidal intensity and gotten through it very well to live very good lives, too often without the support they needed in the treatment system, but through their own resiliency and the support of family and friends. Their insights have informed us as much about what has to be done as the contributions of all the professionals. We're now about 10 years into the challenge of developing and implementing zero suicide. Indeed, seeing implementation on many continents and in many different healthcare systems. And the timing makes this a great opportunity to come together to explore this topic. There are several reasons for this. First, it's still a problem. We still have people who don't get identified and don't get supported in primary care. About 45% of all people who died by suicide had been engaged in primary care but hadn't gotten the support they need at the time of their death. We also continue to have excessive rates among people who have been in behavioral health care, have been seen in emergency departments, and sadly, the highest rates of death that we see anywhere are among people who just left psychiatric hospitalization, where we would hope and expect that they'd be better off for that experience. So we still have work to do in the systems where we're supposed to be doing this work. Second, with this amount of experience in implementing zero suicide, we now understand crystal clear that in programs that have implemented zero suicide thoughtfully and systematically and have stuck with it, they've achieved reductions in suicide deaths among people under their care, often 40% reductions in death or higher. And with that, we also understand that implementation that is incomplete, that focuses on training staff or a screening program or adding a form for safety planning to the medical record, don't work very well. It would be the equivalent of heart care, doing blood pressure checks, and then leading to a little counseling session about diet or exercise without access to the good stuff that cardiac care can provide. We have good stuff too, and it's essential that people receive it. So we understand that zero suicide implemented well achieves great things, and that incomplete implementation is insufficient. So it's time to double down and understand what it takes to do this well. So I deeply appreciate your presence and participation in this event. I hope you enjoy it. I hope you learn from it. I hope you leave it rededicated to the task of providing suicide-safe care in the settings in which you work, continuing to improve if you're working on this already, or getting people together to think about how to commence implementation if you're not doing it yet, because it's possible and it's necessary. And we have to work toward the audacious goal of having no one die in our care, as challenging as that may be. I wish you well today and going forward in your work. Thank you.